Welcome from the 10th IAS Conference on HIV Science, which is taking place in Mexico City. Today is the last day of the conference, and we are in conversation with Ntando Yola, who is the lead community engagement manager at University of Cape Town Clinical Trial Unit. Ntando, is there a disconnect between biomedical science and social or behavioral science?
Thank you, Shobha. Thank you for having me. And so that's a very tricky question, and I think it really depends for who you are asking. But I guess you're asking me now. So I really think there is some level of disconnect. There are efforts that really have been put to really make sure that there is no disconnect, because it's very critical. We cannot really just go one way and biomedical and not consider the aspects of social and be it you call it social political or whatever social or structural issues. So I think we really come a long way, I would say, and there are attempts to really try and work on closing that gap and that disconnect between biomedical and social, because it doesn't make sense.
So there needs to be more collaboration between the two as of now?
Totally. Collaboration is the only way. And I think, it really, as I've said, it really doesn't make sense to just think that any health issue will be addressed because through biomedical interventions. It doesn't. I mean, we talk of a range of issues. People are people, and they live in communities, and communities are dynamic in their own. So there has to be means of really making sure that whatever we find biomedically does complement what is happening at a social level.
Is scientific research always driven by public need?
You're asking me very difficult questions.
No, but you are working on that.
No, I am.
Yes.
And I think in research, really, I do think that largely it is really driven by needs, to find new HIV prevention approaches that are biomedical, and be it its treatment or prevention or technologies. Really, they are driven by a need that is there, so that we could really continue improving the lives of people through biomedical intervention. So I think in that sense it is. However, I do think that you do get elements along the way where you really find that some of the research that happens doesn't really as much as necessary consider the community's interest. And I think that is where communities need to be organized, understand research, so that they're able to have a voice in really saying, this is for us, this is not for us, therefore this and that will happen, but that one we really don't see that it should happen. And in fact, that is what ethics are anyway, right? In terms of really making sure that any research is informed by communities, so that at the end of the day, when it becomes successful, it's able to speak to the exact needs for which it was designed.
Ntando, from your experience, from your personal experiences, what are the impediments in translating research into action? It has been done, the tool is there. So what are the impediments of translating into action at the ground level, and how can we overcome them, or how are they being overcome?
Yeah. So I think it's really the fact that research is science, and science is very complex just by design.
Yes.
And the fact that the solutions that science is looking for often are issues that are affecting people who are underprivileged. And science in its nature is led by people who are privileged in terms of,
Yes.
of academic qualifications and other, things that really relate to that. So so you kind of have high level science that has got to provide solutions for the communities. So how do we then translate? And I think that's exactly where the impediments are in terms of really making sure that we bring as much as possible that disconnect together to translate the science, so that people who are going to be part of the science really understand what it means. So I think we have heard examples, especially in South Africa, where we had the treatment action campaign, where you had community people who were, communities who were forced by a need to find life-saving medicines, and they really had to understand the science, and science was translated to them. There were a lot of mechanisms to translate science, and I think there is a whole lot that we should be learning in that. Now, compare the fact that there was a need for treatment, which really was great, because people could easily see people perishing because of a disease. Now, when it comes to prevention research, it becomes very difficult because we working, somebody is alive today and they'll contract HIV, for instance, just as an example, tomorrow. But before they contract HIV, it just is not in their radar. It's not in their thinking. Right. So you have layers and layers of really working with communities to basically say, what is it? How can we then make you to be interested? And as almost as asking them to, out of their daily lives where they have other pressing priorities, that they have to deal with. So there are a lot of mechanisms that we really need to employ, and really to be able to first mobilize communities, so that we realize that actually, as much as we have a lot of advances have been made in terms of finding treatment, and HIV is not as a visible threat as it has been, but it still is there, and it still affects the quality of life of people. And nobody who doesn't have HIV today should have HIV tomorrow. So and that is where then we get to start translating the science, so that it really speaks to those issues. We make that case so that people become very much interested and say, as part of whatever else that I'm doing, I think this is also a very important cause for me. It needs a lot of investment in terms of time, in terms of work and methodologies and approaches to break down the science, so that it does speak to the lives of people, and it also integrates to what the lives of people are about. Otherwise, if I just go into a community and just say science, clinical research, placebo, or whatever terms that I bring, I will lose people. So we need, and part of our role is to make sure that we work with people so that we don't lose people, but we still appetize people to take part in science, because I think science is strengthened if people have a role to play.
And that, I think, could be one of the reasons for that seemingly low uptake of PrEP.
Oh, yeah. Totally.
First of all, as you said, that it is more difficult to roll out prevention tools rather than treatment tools.
Yeah.
And another thing, so PrEP uptake has been low as of now. And another thing which comes to my mind is the female condom, which did not take over. So how do we learn from the failures here, so that in future that is not repeated, and what needs to be done more for the PrEP uptake to increase? And also the female condom, maybe it's not, but it's to some extent it's part of HIV prevention.
It is part, because I think that's exactly where we're at. I mean,
Yes.
I think, so here's one of the things that we always say, and again, to emphasize your point when we engage with science, that science gets excited by new inventions and what next is going to be exciting, and let's forget what it is that has been found. And that's just one of the critical areas where we constantly, as communities, have to pull, science back to say, if we find the next modality, how are we going to make sure that it is accessible? And there is a lot of uptake, for people who really need that. So let's then talk about the lessons that you're talking about. For instance, let's say contraceptives, which fairly have reasonable uptake, and of course it also has its own issues and its own politics in terms of integrating it within people's lives and people's daily interests. But still, there's a lot to learn out of that, and I think so. It's always very difficult to really make a case to really say this is how other programs or other products have really thrived. But I think one thing that really comes to mind, and something that I always talk about, is that communities really have to own some of these programs. In fact, all of them. They have to own how science happens, but as part of that ownership, we really have to constantly move and really capacitate communities so that we are able to be, to gather different forms of evidence that we are going to be able to use to say, here is evidence. As first our voices, but some forms of very systematic approaches of gathering evidence that we're going to use to say, let us learn from other programs, from other diseases, or from other health approaches, so that we can be able to use them into this, and we bring that conversation into what is currently happening in terms of the current clinical research.
So, preparing the community well in advance is important, amongst other things, for a proper rollout of what we have.
Yeah.
Other than preparing the community, what are the other impediments you think which could be there in the rollout of a new tool or technology?
So it is. So you sort of have tiers of these impediments, and some of them they start at political level, because that's where the power lies,
Right.
And therefore there has going back to my point about being systematic in terms of how we engage, capacitate, mobilize communities. We really have to be able to have an understanding of the whole spectrum, from at highest level to the basic level of grassroots. So I think the political aspect, and unfortunately, and again I'll make an example about South Africa, that during the treatment times where government really had a very strong position that there's ARVs are expensive, we cannot provide them, it was easy to be militant and say we demand it. But today it's very, we have a government who says, oh no, there are systems, we have to go through these processes, but we still need to do it. And most of the things are valid in terms of how all of this work needs to happen in order to have a product that is accessed by communities. Now we find ourselves as communities on a back foot, because we have to understand systems. We have to understand how policy works, how procurement and systems work, and all of those complex systems. So it really requires us to be, to really understand those and learn and put a lot of time in really understanding those, because the battles are won in the streets. However, the battles are also won very much strategically and systematically, and that requires us to be able to understand and teach ourselves about the systems of how governments work, so that we are able to have an impact and be able to identify pressure points that are really going to yield the results that we have. And also work, again, I'll go back to the point that you made about the importance of the broad spectrum of social sciences, because social sciences really study, communities, and then maybe one would argue that health economics as well are part of that, and so we really have to work with science, with clinical scientists, to say it's not just about you saying here is a product, and I don't mind how, I'm not really bothered about how it gets delivered, because that is what we promise communities when we work with. So that whole continuum has to be understood in terms of how, what does it mean to have a biomedical product from conception, from ideation through clinical research until the product is final. But that is not the end of the job. What happens in terms of really making sure that we understand systems that are going to make sure that a product really goes into the hands and in the mouths, if it's an oral product, or into people, so that it makes the impact that it's supposed to do. But here's one of the things, though, that's also very, very interesting, is the fact that we currently know, we have lots of examples with what is happening now, and which makes it difficult when you ask what is it that we must learn in other products, because generally health in our developing countries are really an issue. The health systems are a serious issue. So we don't really have anything to learn from in terms of what is happening and what has happened. So we constantly also have to work with the things that are really happening at that point, try to fix those issues, whilst we then make a case about what we learn in terms of fixing those systems and issues to have implications for what is in the pipeline.
Yeah, because I was very impressed by one of your remarks when you said where people don't even have clean drinking water.
Oh, yeah.
So can
Very
you say
sad.
a little bit more on that?
No, and
Yes,
that's
very true.
yeah, it is very much true that a basic health is a human right, and we have to fight for people to have access to life-saving medicines and approaches, and that seems to be very difficult because of a number of reasons that we know. But I think what makes it even worse is the fact that there are communities who are in the periphery who cannot access, clean drinking water. The basic of the basics. That's just one thing that you cannot live with. So it already then makes it very difficult, and I think that makes a case for the fact that we cannot continue as community and civil society leave things onto the hands of those who are powerful. We constantly have to really work and deal with those kind of issues to really make sure that people have access, and we work systematically and we push, and so that we achieve what is needed in as far as health is concerned.
Thank you, Ntando. We were in conversation with Ntando Yola, who's lead communication community engagement manager at University of Cape Town Clinical Trial Unit. Thank you very much.
No, thank you very much. I appreciate having me.